Well, great. Welcome, everyone. My name is Matthew Lyonar. This is the CPCRC Learning Series number 3, Rural Team-Based Primary Care, a case study for PEI Exploring Implementation and Transformation. So, just make sure this is, there we go. To begin, I'll start with a land acknowledgement for Prince Edward Island, which is where I and our panelists are today. So I'm a first-generation settler on Epwick in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. And I also recognize the treaties of peace and friendship and their importance in guiding nation-to-nation dialogue. I'd invite you to add your own land acknowledgement in the chat, and a little bit about the Canadian Primary Care Research Consortium. So the consortium is a Canada-wide group dedicated to strengthening and scaling primary care research across the country. It was founded through the partnership of primary care researchers and clinicians, patients, policy and decision makers, and practice-based research and learning networks. CPCRC strives to be home for all primary care research. We work to improve the visibility of primary care through our developing data platform of electronic medical record data linked to practice and patient survey data. Together, we are fostering innovation, advancing patient-centered care, and ensuring that research directly informs practice and policy so that primary care in Canada continues to grow and deliver health outcomes for all. Yeah, sorry, that's my little blurb. Again, for those that I haven't met, for this series as a whole, I will be your sort of tour guide, I guess. We're using a road trip kind of theme, drawing off of some of the terminology that we use here in Prince Edward Island, the Primary Care Roadmap, patient medical home, patient medical neighborhood. So we're gonna, we like to think of ourselves as a tourist destination, so come on the journey with us. For me, I'm a government-funded research scientist. My work focuses on access to primary care, informed kind of by two early career things for me. One, I started my career as a paramedic, and my recent research in that area is about aligning patient need with service delivery, which the vast majority of people who call 911 are not dying, they're looking for access to care. And so that's what brought me here. The other one is, and it ties into this idea of a road trip. My undergraduate and my master's degree are in geography. And when I say that, I think the key takeaway is around spatial access to care and the proximity to care. And so I've done a bunch of work in that area as well. I'm also the PEI lead for the National Health System Impact Training Platform. This is what brings health services research, embedding it within health organizations, and various other affiliations that I've put on the slide there. As already mentioned, so I'm going to give a bit of an overview of this learning series. We've got this session today, as well as ones in October and November. When I was doing my degree in geography, people would often ask me, like, why was I doing that? And this is when I was working as a paramedic, I'd make the joke that I couldn't find the hospital. I hope that I don't get anybody lost on this trip that we'll do together. There's another piece here. I think there's a joke about, turn on your John Denver or whatever your road trip song for country roads. We're going to leave the city and we're going to see what's going on in terms of the rural settings for primary care. For this session in particular, we're calling it Getting Oriented to the PEI Primary Care Roadmap and Where Are We Going? I think of it a little bit of, we all have this idea about what the destination is without necessarily thinking about where we're coming from and recognizing that we might not necessarily be coming from the same place. And that's an important piece to acknowledge and something that we'll, hopefully address as we go through the series as a whole and as we go through the session today. So a couple of fun facts that I'll say about Prince Edward Island, and part of why we talk about rural team-based care is the PEI is predominantly rural. I think of the Vinyl Cafe, for those that remember that CBC series. We're not big, but we're small. And I see that as our strength and our advantage. So there's a blast estimate, we'll say approximately 180,000 people that live in Prince Edward Island. Interestingly, that also makes us Canada's most densely populated province. And so even though we're talking about rural care, and we certainly have we're famous for our potato fields, we don't have that vast wide open spaces that every other province in Canada has. We are fairly densely populated. Lots of small towns and villages. We have one larger town in terms of Summerside, and then another geography term for you is the micropolitan center, which is here in Charlottetown, our capital city. We do have one provincial health authority, Health PEI, and we'll feature them in session number 2. And the other piece to that, I think that's worth mentioning is, and we'll talk about it a bit more in session 2, is the intersection there between primary care and specialty care, and particularly how there's a lot of interaction with our neighboring provinces for subspecialties. The other piece around rural care that I'll mention, and just rural settings really, is that influence of technology aspects, where we talk about less reliability in terms of cellular and internet connectivity and the challenges that can go on there. Seasonality plays a big part, both in terms of our own industry around farming and aquaculture, but also tourism. And then the other piece, which is fairly common to other rural settings across Canada, is higher proportions of older adults and lower proportions of the population with more advanced education. So those are some of the characteristics about PEI, and those will come up as we go through the various sessions. Today we'll be talking about the primary care roadmap as sort of the foundational piece of the shared vision for transformation in primary care across the province. I'm going to touch on common language and terminology, and then we'll have a panel discussion around patient priorities and the work that the government has done. In session 2, we'll have Health PEI join us, and we'll talk more about the state of the current evidence around transformation and this idea of, like, are we building something new, or are we renovating what we have? And how do we put some parameters around classifying the different types of teams? And then in session 3, we'll be talking about building capacity and supporting existing practice and some of the future work that we're going to be doing through the Health Research Network here at UPEI. At the high level, I use this as like an image to think about, again, on that road trip analogy. When we say patient medical home, not all homes are the same. And so you go on Realtor, you'll put in your search parameters, and maybe you're looking for a 2-bed, 2-bath, semi-detached. Maybe you're looking for a 4-bedroom, three and a half bath, large acreage farmhouse. And these are different things. So how do we define these things? And what are the different features of, particularly within the rural context? But I think that also makes it applicable within our urban centers as well. And so I mentioned already, I want to touch on terminology a little bit, because I think we're really good across Canada, not just in this way, but in many ways, of using different words to say the same thing, or using the same words, but that they mean different things in different places. And so you've already heard me use the phrase patient medical home. That's sort of the core piece here on PEI around what a team-based care looks like. And so this can be called a patient-centered medical home. I know our friends in Newfoundland and Labrador say family care team. Family health team in Ontario is another term to get used. Really, this stems out of the College of Family Physicians of Canada and their vision for team-based care, providing that coordinated, comprehensive, accessible to patients in a team-based setting. For PEI, we have primary care networks. We have 5 of them. And these are really a support system. Again, this might have a different connotation or a different application in different provinces, but these are regional health delivery networks serving as a support for the implementation around patient medical homes. And then patient medical neighborhood is the other term that we use here. And to me, I like to summarize that just really speaking more broadly about maybe getting into that nuanced difference between primary care and primary health care, but the broader health and social continuum. So these are the network of care built around the patient medical home, involving multiple providers and services outside of the clinic, including community, hospital, and social supports. You've heard me say a couple of times already, access to care. We look at that as the ability of patients to obtain timely and appropriate health services, including both the presence of a provider and the availability of the services. That may be in terms of the appointment, but it also may include travel proximity, which is something that's really interesting to me. Team-based care, multiple healthcare providers working together to deliver comprehensive, coordinated, and continuous care. Virtual care is another term that gets thrown around a lot. We define that as the use of digital communication technologies to provide clinical services remotely. And this is really important in terms of the ability to rethink what proximity looks like, bridging some of those gaps that happen because of distance. Integration is another driver within the transformation work. And this is a coordinated network of healthcare organizations under unified governance, aiming to improve healthcare delivery efficiency and outcomes. And that ties then also within the quadruple aim, which and I use that here in terms of, because that's the term that was in the primary care roadmap, as opposed to quintuple aim as it's evolved to be. But as the quadruple aim, focusing on enhancing patient experience, improving population health, improving provider experience, and reducing costs. A couple others, just in terms of rural health, and one of those parts, there's a whole other aspect to rural health around the health services or interventions delivered in settings that are designated as rural, which might be as easy to say as not a major metropolitan center. And then for our discussion here, we're going to try and keep it as tight as we can around primary care and that Starfield model of first contact, coordination, comprehensiveness, and continuity in terms of functions. Okay, that's all the dry stuff. I'm going to get into the discussion, and before I have our panelists introduce themselves, I'm just going to share this one image. And what I wanted to highlight here is patient at the top. And you know, in that next box where it says citizen, you could put taxpayer, you could put voter, maybe, you know, this is where client, consumer might be other terms for patient, but really I wanted to highlight that this is driving this discussion. And part of that is through the democratic process and the values that we hold as Canadians, you know, the sacrosanct kind of sense of healthcare and the value that we place on it. And so this was really the linkage between having our patient partner join us as well as our government and department representatives. And so I will give them the space to introduce themselves. I'm going to stop sharing my screen for the discussion. If I can go there, okay. And first I'll call on Tim to introduce himself.
My name's Tim Edwards, and I am the patient partner for this presentation. My wife, Colleen, and I have retired to Prince Edward Island about 11 years ago. We live in North Rustico, and we belong to the Gulf Shore Medical Patient Home here.
Thanks, Tim. We'll go to Kelly next.
Hello, everyone. Welcome. My name is Kelly Rayner. As Matt says, I'm the Assistant Deputy Minister for Community Health and Policy at the Department of Health and Wellness in PEI. I also have held roles since this roadmap started. I've worked in the department, I've in the ministry, I've worked in the health authority, both looking at the operational side and doing some of that planning as part of the roadmap, as well as launching it and moving that initiative forward on the ministry side. So I'm very happy to be here.
Thanks, Kelly. And Lauren?
Hi, everyone. My name is Lauren Kelly-Wayman, and I am the Executive Director of Community Health and Pharmacy with the Department of Health and Wellness. So I work with Kelly every day. And so I joined the department about 8 months ago. And previous to that, I was in the operational side of things at Health PEI, which is our health authority, working in physician services and medical affairs. So I'm happy to be here today and talk about kind of my experience with the primary care roadmap.
So Kelly, I'm going to go back to you for question one, and just you kind of alluded to it already in terms of the work that you did previously on the roadmap, and so I figured it was a good one to send your way in terms of some of the rationale around the creation of the roadmap and how it came together.
Thanks, Matt. Sure, happy to answer that. I'm going to start with the ministry, and prior to COVID, because things seem to be before or after COVID, we were working on a rural health initiative, recognizing that there was gaps in primary care in the rural setting. So we were doing consultations and looking at what's the best practice in the rural area. Even though PEI is rural, we do find that there is some differences in the more remote areas of PEI versus where the cities are. And so looking at that, we were trying to look at where are the gaps in services, what the services are closer to home for those residents, because transportation is a big issue. And then COVID hit, as we all know, and in the primary care world, it really impacted. It was a big disruption, but in PEI, the primary care services really, some of them stopped for a period of time, and others were greatly reduced to deal with the COVID response around screening and assessing people and standing up a number of COVID-based services. So what that meant was the regular screening that happened, the chronic disease management, and some of the routine care was paused for a period of time. And as you can imagine, the need was great when we started to reopen our services. The staff were burnt out. We saw a lot of people retire early or move on to other things. We had primary care services in that process. In that same period of time, we also had a big boom in immigration. So we had a lot more, our population grew. I don't have the exact numbers, but our population used to be about 160 or 70, and now we're at 182. But the health services didn't grow with that raise in population as well. And the wait list considerably went. The other thing we learned in COVID was that we can do things differently and efficient. So we learned that team-based care and collaboration across sectors was really valuable and efficient. We were forced to look at innovation and virtual care, and we launched virtual solutions that we had never used in the past. And we looked at how do we do things a little bit differently. So with the work on the rural action plan or the rural initiative and the learnings from the COVID-19, access to primary care became a big priority of government all the way to the Premier's office. And there was a joint collaborative between the ministry and the health authority to come together to look at how do we improve access to care. So some of the things we were working towards was expanding access to primary care teams, increasing evening and weekend coverage. So not just have the Monday to Friday. We know that some people can't get time off work. They can't get to those appointments. What does that look like? We also wanted to broaden the types of services in primary care versus just the going to see your doctor get and service. What other things can primary care do? For example, cervical screening and things like that. We also wanted to improve navigation for both the health workers and patients and their families to try to make it easier, because we know the health system is very complicated. We know that they don't know where to go a lot of times. And so we're really trying to increase awareness around where to go, as well as making that seamless and ensuring that if you're seeing a private physiotherapist that your doctor might have ordered, that they actually had that communication back. How do we ensure that those warm transitions happen and the patient is at the focus and trying to look at that? And the other thing we wanted to do was really look at chronic disease prevention, because that was one of the big areas that we had paused. We really wanted to make sure that as we moved forward, there was a strong focus in that area. And from those guidelines, a collaborative team came together to develop the primary care roadmap. And I'll just say, so we had a 2-year roadmap, and our plan was to, once that roadmap was done, we were going to develop a 5-year primary care strategy. But after the 2 years, we were just getting started, and we realized this was the strategy. So we continued with our strategy over the next over the 5 years to try to move the markers to improve primary care access, because our goal is to have every Islander have the care that they need where they need it in a timely way. So that's where our roadmap came from.
Great. So Tim, I'm going to go to you in terms of, if you think back 5 years ago, before the pandemic, that kind of marker thing that Kelly pointed to, that everything was, before COVID or after, right? So think back to that time 5 years ago, and your relationship with your family physician and how you were accessing services. What was working well? What would have been considered a challenge?
Well, I think the answer to that, Matt, is the same, and it has to do with access. So when we first came here, as is the experience of everybody who moves to Prince Edward Island and probably every province now, you don't get a family doctor right away. You go on a list. And Kelly had mentioned a waiting list. And so we go on a list, and we're waiting to be assigned a primary care physician. And so we were, I think, super fortunate, because we only waited I think about 1.5 to 2 years before we actually got assigned a wonderful doctor. Big shout out to Kian Omaran, Dr. Omaran. And so he is our physician, and we belong to his clinic, or the clinic, here in Gulf Shore. And so before being assigned a doctor, primary care was access was a real headache. So you have to go down to clinics that are open throughout the week in different locations. And if you're fortunate and you get there at such and such a time, you can get an appointment for that day, but you don't always get an appointment for that day. And you may have to go to another place the next day to try to get that appointment. Of course, there's a lot of drawbacks to that because you're not going to someone who knows you. They may have a record of you somewhere, but there isn't any um, there isn't any base of knowledge of you, and there isn't any really follow through either. So you might go there for something like sleeping issues, but and you would get a referral, or you might get a prescription, or you might get a referral, and then but that's it. Like you're not gonna stand in line to go back and get a follow up on that. So access prior to having um, our own medical doctor was a headache, and I know continues to be a problem within PEI, and as I say, a lot of places in Canada. And so, but once we got our doctor, Dr. O'Marin, and became part of this clinic, access was on our side. And so whereas access was our enemy, now it's our friend because we have access. And I was diagnosed. Yeah, I mean, I've been diagnosed with a lot of things. I've had a lot of issues, but just the access to a doctor who's going to see you through uh, whatever the issue is hugely different. Now, that is so in relation to before COVID. So my experience before COVID was really bad and not too bad at all when I had a family doctor. But the critical piece, of course, is getting off that list and getting into a home, so to speak.
So then I'll go to Lauren for, we go to sort of present state, and Kelly kind of mentioned this, and even Tim is alluding to improved access already for in his patient experience. If we go to current state today, what are some of the things that remain a challenge, and what are some of the things that are starting to work really well?
So thanks, Matt. I think there's a number of things that are working well. And I think one of the things that we learned in the pandemic is when, there's common vision and common goals and objectives, we actually can move mountains and we can do those things fairly quickly. So I think the primary care roadmap really allowed kind of all the key players to come together and have that common vision, have those shared goals, and all be rowing in the exact same direction, which I think has made a huge difference in moving this work forward. The roadmap and the model around the patient medical home really puts the patient at the center, and they're at the center with this collaborative team around them. And so, making sure that there's full alignment within that team, that all team members are working to their full scope, and patients are able to see the right provider at the right time. So, you might not necessarily need to see the physician or the nurse practitioner, but it might be great for you to see the dietitian or the diabetic education nurse, and really utilizing their scope within the teams. One of the great things that we've been able to do in PEI is establish 17 different patient medical homes across the province since the beginning of the roadmap. And I think having that vision, like we're talking about earlier, that's what helped us get to that point. And one of the other things that I think is really great is that within the patient medical homes, it's not like it's a one and done. It's a continuous learning environment. and it's really focused on quality improvement. So each home has practice facilitators that really help to kind of look at what are those processes, what are the challenges happening within those homes, how are they developing solutions inside of it, and really focusing on that continuous quality improvement, doing, you know, plan, do, study, act cycles to make changes in real time, as opposed to waiting for like a broader, I don't know, standard or process or what have you. And I think that enables homes to really tailor, you know, the care that they're giving patients on kind of on a broader scale. One of the other things that I think really worked well is that in PEI, government has heavily invested in our provincial EMR, and having that one record, that one source of truth, has been a game changer for patient medical homes, so that, you know, providers can go in and they can actually see in real time, you know, the notes that anybody on the team is creating. And when they're providing, you know, referrals or consults to other providers within the system, they're able to see all of that background. And so when you're moving from that paper world to the electronic world, that makes a huge difference, especially for patients who may be unaffiliated, moving to affiliated, being able to take that full record with them. And I think when we talk about some of the challenges, you know, certainly, as Tim alluded to, access and affiliation has definitely been some of the big challenges that we've had. You know, when we think about, you know, going on to the wait list that we've talked about, Health PEI has done some really great work around modernizing their provincial patient registry and making sure that those numbers are accurate. And for those that are unaffiliated, what are we doing? What we've seen since the pandemic is that you know, the number of walk-in clinics in PEI has gone down dramatically. And so there was a void there. And so we were able to put into place some unaffiliated virtual care for patients that they can access if they're unaffiliated. And then if they actually need to see somebody, there's primary care access clinics for them. One of the big challenges, I think, which has really come as a result of the pandemic, is around human resources. And, you know, we're no different than anyone else in the country. And actually, it's probably more of a global problem. But it's about how do we kind of take that problem and turn it into an opportunity. So how do we look at, how do we modernize our system? How do we adapt our system to deal with the challenges that we're seeing? So for example, you know, a lot of nurses or allied health professionals, they don't necessarily want a permanent position now. They're looking for more casual work because they're looking for that work-life balance. So how do we design our recruitment strategies to meet some of those needs? And then I would also say on the physician side of things, a lot of physicians are wanting to locum. They're not necessarily wanting to go into a family practice right away. So how do we make opportunities for that, but also provide seamless, streamlined care to patients for that?
That's great. So Kelly, I'll put you on that kind of the hot seat here in terms of the work ahead. I mean, Lauren did speak about the unaffiliated, and Tim spoke about that. Like, and this is a theme that keeps coming, this access to care theme. So what are some of the additional steps that the department's going to take to address those? And the other one I'd raise too is how do we work as a, you know, province to province, some of those dialogues that you're in with our neighbors, you know, in the Maritimes, but also nationally.
Thanks, Matt. So we recognize, as Lauren's kind of expressed a lot of the issues. The other thing in PEI, we're rural, and we also consider ourselves remote. And remote in that, because of our population size, we don't offer all the services that other provinces would provide. So we also have to have referral pathways to other provinces. And so I'll come back to that in a minute. But so as Lauren said, we looked at what are the big issues, and one of the big concerns was the administrative burden and the volume of work on our physicians and our nurse practitioners, and how do we look at that? So the patient medical home, or that team-based care model, looked at, depending on what the patient presents with, the physician and the NP don't have to see every patient. So we're trying to change our culture around having to see the doctor first. Maybe if you have a musculoskeletal injury, you see a social worker. Maybe if you have a problem with your diabetes, maybe you see a diabetes nurse or a diabetes educator. And so looking at that front end when the patient calls about what they're concerned about, doing that triage and looking at the most responsible provider to do that work. So really expanding the scope of the service, the allied health services around the physician and NP. By doing that, we also looked at how do we expand scope of practice of regulated health professionals. So not only can they do what's in their current scope, but how can they do more for the betterment of patients and their families and to support the system. So on the government side, they're regulated. So we've worked with our various colleges, associations, and our health authority around what are the needs are, and looking at broadening that scope through legislation to really make a difference around what that looks like. The other thing we did was the department has an innovation hub or a section that looks at what other kind of things can we look at to help enhance the care needs. And so they have stood up a program called Virtual Hallway. And so, as I said earlier, the wait times are long, not only in primary care, but in specialty services. So with the phase one of the virtual hallway, which we have rolled out, is family physicians can reach out to specialists, whether they're in PEI or New Brunswick or Nova Scotia, those who've signed up, and get real-time advice from those specialists to be able to help provide care to their patient. And often that results in the patients not having to go to province. They have that plan, or they do, and making it much more client-centered around reaching the patient where they're at. We also, in the middle of this, rolled out, as Lauren said, a community electronic health record. And so trying to do that and launching the patient medical home, we would probably suggest you do one and then the other. And so the department led that policy, the initial piece, and then as it got rolling along, that was transitioned to the health authority to roll out. We also we introduced new professions like physician assistants, associate physicians. We introduced psychiatric nurses, things like that can increase our capacity overall. And as people would also assume, we also enhanced our recruitment efforts, not only within the province and nationally and internationally, to try to increase our overall workforce, setting up different kinds of programs around if the credentials or the training isn't consistent in another country, but they come here, having some sort of an upgrading process to get them up to the Canadian standard. So we've done that in several areas to help with that. And the other big piece we did was we have a new physician services agreement. It's the first of its kind in Canada. And what it does is it recognizes longitudinal family medicine as a specialty. And so that recognizing that there's lots of people who can provide primary care access, but really looking at them as a specialist, recognizing their payment. It has some incentives to see more patients, to have more affiliation. And that has really helped us move forward with advancing our primary care agenda. And so also on, as far as collaboration and what we're doing with other provinces, we also have an Atlantic physician registry that allows for physicians who choose to join to move between the maritime provinces. And they can work in PEI, they can do service in New Brunswick and Nova Scotia, and it really helps our maritime area work as a system to try to look at that. The other thing, as I related to the remote piece, we also have umbrella agreements or interprovincial agreements that allows for our islanders to go to Nova Scotia and New Brunswick to see specialty care. And so we have renewed and strengthened those and expanded them where we need to ensure that we have the services. And in some cases, we might have lost a specialty because we lost some staff or physician specialists. They might go. So it tends to be fluid, and we need to continue to monitor and look at that. And the other opportunity we have in the ministry is that we do work at a national, provincial, territorial level. So we also have tables where we can bring our concerns around primary care, team-based care, recruitment, workforce, whatever that is, and share that learnings across the country and take some of those best practices. And organizations like Healthcare Excellence Canada and a number of other organizations bring people together, not only with the formal government FPT relations, as well as organizations that are focused on improving quality of care. And I would offer that with other organizations that fund grants, the CIHR and others that we work with to try to improve capacity. That's it for now.
Tim, you mentioned a bit of the changes that you've seen already with in your clinic in terms of the shift from the clinic idea to the patient medical home. Can you just expand on that a little bit more in terms of what you've seen as a patient to all of these different parts that Kelly and Lauren have talked about happening in the background? What do you see, when you go for, an appointment with whomever it is that you're going to see?
Yeah. So first of all, just very appreciative for all the work that's going on to provide access and good care. I've told Matt in the past that I'm a huge fan of PEI's medical system. I've always been, and they're not paying me to say this, folks, but I've always been given the most excellent care. And it's never been an issue of the level of care that I've had access to. It's just the issues have been, and for us has been not so bad, access to that medical care. Post COVID, things that we have noticed up here on the North Shore is that I believe Dr. Omar, and I stand to be corrected, but I believe he was an early adopter to this nurse practitioner role. And so we have a nurse practitioner who's working within our home now. And we also have, it just seems like we have more staff. There's more nurses and there's more people available. And our home is really trying hard to make things move a lot quicker. So we have a lot quicker access now to medical appointments. We also have, our doctor. It's funny. He calls me up sometimes, and they make these appointments for me to talk to Dr. Omarin, and so Dr. Omarin comes on, and I'm not used to speaking to doctors, but he's a great guy, and I get to talk to Dr. Omarin about issues and things like that. So he does that. Another thing that they're working hard at is he has one issue Wednesdays, which we always chuckle about because as we are complex. The older you get, the more complex you get, and so our needs are pretty complex. So sometimes it's kind of hard to limit it to one issue Wednesday, but which is really just a variation of a drop-in clinic for people that are on his list. So he's trying to make access available to his home patients, and so you could just drop in on a Wednesday afternoon and see either the doc or the nurse practitioner. And so these are things that I can see happening. One of the things another thing that has happened is miraculously we have a new facility, which is quite amazing to us. I don't know exactly what the plans are because I'm not privy, but I am nosy. So I did call up the secretary and tried to, what is all this new room all about? And she wasn't really forthcoming, and I didn't want to, act like somebody that was important that she needed to answer to. But I did get the feeling that there's a lot more space, and perhaps there'll be more variety in the type of care that comes through that medical home, because it's double, no, probably tripled the size of our medical clinic. So there's that has happened. My only concern at this point is that as much as medical homes, our experience has been positive and our access is good and our care is good, and increasingly is that when we get referrals to other specialists, I think you guys call them, to other specialists, sometimes that takes quite a long time. And sometimes it's you're not, I think there's a policy, maybe if there's nothing wrong, they don't contact you or something like that. But that's, from my perspective, I just sort of feel it'd be really really reassuring to kind of get a call and say, look, your MRI looks good, don't worry about it. Instead of just sort of not knowing for sure. But yeah, so that would be my only concern at this point. And like if I can, I don't want to hog time, but I just want to say, like, one of the things, like post COVID, and I mean very post COVID, in my medical home was right near the when we started to actually see our doc in person again. And I went in for something, and turns out he said, "Is there anything else that you want to tell me about?" And I said, "Well, I've got this lump on my head right here, doc." And so he just took a look at it, and uh, within within a month and a half, less than 6 weeks, I was in Moncton having a significant brain tumor removed. And so MRI, like I got the MRI was set up quickly. The referral got done quickly because we don't do we do MRIs, but we don't do like neurological surgery on PEI. So it got transferred away. But it all just happened, like, honestly, I'm just so thankful as a patient. Like, that's just amazing to me that that happened so quickly. And so that was a really super quick turnaround. And you know, gotta take my hat off to what's going on in PEI for that.
I think that's
I'm done.
a great story to add, Tim, in terms of to speak to exactly some of the stuff Kelly said around that connection with our maritime neighbors, and that referral pathway is a different pathway when it's out of province, and this broader space. In the interest of time, I'm gonna jump to some of the questions in the chat. There's a couple there, and if others have chat, you can put your questions there. You can raise your hand. I'm gonna go back to Lauren. I think it was Lauren who mentioned this. The questions from Paula around, can you clarify, are each medical home affiliated with a practice facilitator, or do they have their own as part of the team? I think that's that network versus home space.
And Kelly, you can correct me if I'm wrong, but I believe that there is a practice facilitator connected with numerous different teams. And there's also then kind of clinic coordinators that kind of help within the clinic themselves. But the practice facilitator really has that kind of next level training in terms of like that change management, that kind of help teams move along in their change journey.
I'm just to it. When we first started our model, and it's evolving, and you'll hear more about that the next session, but what we learned was that the way our healthcare workers have in the past trained is not in a team basis collaborative care model. So while they all work together, the practice facilitator was assigned to, I think they're shared, to the teams to actually literally help them work together as a team, so that they say it's our patient, not my patient, really changing their mindset, as Lauren said, around that change management. And then, as Lauren also mentioned, and looking at that CQI process. So as a team, they come together and look at, what is this situation or this area that we want to improve? How do we do that together? And those things have been key enablers of the success of bringing teams together in a patient medical home.
Thanks. And yeah, I'm going to go to the next question too from Penny, prefacing it with stay tuned, because more on the implementation will be discussed next month in October. But Penny's question, a couple questions: how are you measuring attachment or access, and how are you keeping your patient registry up to date? So Lauren, you did speak a little bit about that. And then she also asked, are providers required to pull unattached from the registry? Maybe you want to talk about attachment, Lauren.
Sure, and I'll do my best because I'm not at Health PEI at this point, but I will do my best. So in terms of keeping the registry up to date, I know since last fall, there has been a lot of major work done on the provincial patient registry, basically to go through and clean it and make sure that those that are on it still need to be on it, that everybody on there is seeking to be attached. And to make sure that they have contact information and make sure that it's pulling in real time, and that physicians and nurse practitioners who are building practices are pulling from that registry. And so I do know those two things for sure. In terms of how they are measuring attachment, Kelly mentioned the physician services agreement, and there's some work underway to work with physicians and in their patient medical homes, what the team actually, the number of patients that they're caring for. And so I do know that there are some goals, but I can't speak to exactly what those numbers are. And then from an access point of view, historically we've always measured third next available, but it's also been a very manual measure. So, as we get more in tune with our, provincial electronic health record, we should be able to get the really rich data to help us kind of inform what should those metrics actually look like, what's kind of our stretch goal, where are we at right now. So yeah, hopefully I answered the question.
Got the thumbs up. That's great. Nadia has a question also. I'm just going to kind of skip to it. So the balance between continuity and access in primary care, and again, this is something like familiar to me in terms of from my paramedic background about turning off the patients making the trade-off for convenience instead of continuity. And this is definitely a challenge. If access is not convenient, then there's other places to go. I know initiatives like Pharmacy Plus is another one we haven't talked about today, but things like that, where even to Tim's story about before he was attached to his family physician, that sort of sporadicness of or episodic care. So what are some of the things that are going on in terms of, that balance between continuity and access to care? I don't know, Kelly, or
I can start with that, and others can add. So one of the goals is access, and we know that longitudinal family practice is really important for long-term health of residents, but they have different needs, and depending on what they present with, it might be a virus that they need treatment, and then they don't need follow-up care unless they get worse. And so we have stood up, as Matt said, Pharmacy Plus, which is the ability for islanders to go see their local pharmacy and pharmacists to have some common ailments. And I think we're at 35, is that right? At 35 common ailments that they can go and see that. That has been, we've seen hundreds of thousands of people through that program. That's not longitudinal family medicine. And we recognize that. We also stood up virtual care for unaffiliated people, and we're working towards kind of virtual for all, but recognizing virtual care doesn't work for everything. So we need a multifaceted approach, with patient medical homes being the gold standard, that we want to have patients go, we want them to be referred to that longitudinal primary care. So that might be seeing their diabetes educator regularly in different pieces. But some patients, I'm aware, and this is something that the next session you'll probably know more alike. At one point, some providers were doing one issue per appointment, And we know that health is complex and sometimes several things are combined. And so we do want to have our goal is to have all islanders affiliated with a primary care provider and a patient medical home. But we also want them to get the care they need at the right place, the right time, and what they need. And sometimes it's not longitudinal, and sometimes it is. So trying to have a comprehensible, flexible system that meets all of the needs. Lauren, do you have anything to add?
Yeah, I was just gonna say the patient medical home is like the center. Well, the patient's in the center and the patient medical home is wrapped around that patient. And it's one part of a larger ecosystem of overall care. And so, a lot of what Kelly is talking about is really in that patient medical neighborhood. And how are we going to, integrate other care providers, whether that be acute care or a specialist or, the physiotherapist clinic down the road. Or Pharmacy Plus, how do we integrate the care that patients are receiving, outside of that patient medical home so that it's seamless and so that the care providers know what each other are doing, so how it all plays into providing really great care for that patient. And how do we reduce barriers? How do we make that easier for our care providers? How do we make it so that it is seamless and the patient doesn't have to repeat their story 10 times to 10 different providers?
Yeah, I think that's great. I'm going to do a last call. If anyone else, again, if you want to, raise your hand and come on camera to ask the question, or you can put it in the chat, that's fine. Laura, I'm just going to come back to one other question about, sort of the where do we go now, right? So the primary care roadmap did have some enablers in there and, different measures of success that it was shooting for. Mm-hmm. So how do you take the progress today to guide future phases in terms of the ongoing work?
Yeah, so I think it's being, we are part of a learning health system, and it's never going to be a one and done. It's going to be continuous evolution of, how do we get to that kind of ideal state that we're trying to reach for. One of the things that I really appreciated that Tim said is just, how well the system has worked in certain instances. And I don't think we do a good enough job of celebrating when things are going really, really well, because there's things that we can learn from how well that went for him. I think there's a couple of different things. I think integration, like I was just talking about, is going to be really key to kind of part of that next strategy. And then the other thing that I think is going to be really big is navigation. So there's lots of different resources out in the community. How do we help patients know where to go for what? The healthcare system is a huge, complicated, complex system. And sometimes even those who are in it don't know where to go. So those that don't have a really great knowledge of it, potentially, of how to navigate through it, need some help doing it. And so I think, there's a lot of value in public messaging and building that knowledge base so people know where to go for what. And I think it's also a balance of the allied health providers that we do have, making sure that they're working to their full scope so that they can help and take some of the load off. It's about changing the culture, like Kelly said earlier. You don't necessarily always have to see a physician or a nurse practitioner. How do we really focus in and make sure that you're seeing the right provider at the right time?
I think that's a great ending notes and segue and stay tuned, right? Because many different paths. And so session number 2, save the date. It's in the chat there in terms of the registration link, October 22nd. So we'll talk more about this work around implementation. And our team here at the Health Research Network has also done a scoping study. So we're going to be contrasting what's there in the literature with what the implementation looks like with our panelists from Health PEI. So I guess buckle up, stay tuned, and we'll talk more about both those things in terms of the latest evidence and the implementation work. We're coming up to time. I want to thank everybody who joined. I want to thank the consortium for giving us the opportunity today to share about the work that's going on here in terms of with PEI's transformation. Big thanks to Tim and Kelly and Lauren and everyone for joining. My contact information's there if you have anything else to add, and we'll see you next month.